going to take you on a brief review trip of some of the information we heard scientifically over the last couple of days and hours, and bring you some current research and some thoughts on what we might think about in moving music fully into the science. The thing is, I decided to open with this because what we present is a totally new concept in treatment. And I believe that music is a treatment modality. Let's go through a little bit of physiology. Humans, as we heard this morning from Dr. Tremo, we're foremost emotional animals. And fear is one of the strongest, if not the strongest, emotion, which causes physiologic dissonance within the organism. The amygdala, the thalamus, and the hypothalamus thrusts the organism into a 911 fight or flight mode. Now, as you heard this morning, the brain's interpretation of sensory information causes our physiology and our systems to respond. And 99% of those responses are instinctive. We don't have to think about shutting our ears. We don't have to think about what it is. We get a vision, our visual sense sees an item, an object, and we instinctively respond. We can't underestimate instinctive human physiology, especially when it comes to pain. The brain receives information only through the senses. If incoming information is to be dealt with by the brain, it continues up through what I put down here as REST, the reticular activating system, which is kind of like Brillo of all kinds of nerves at the base of our, or at the top of our spine, at the base of our brain, that filters information further up. And the thring, which is the thalamus and the limbic system. I don't want to argue definitions with Dr. Tremo, but I was always told that limbus meant ring. So in any case, it's the limbic system, which is that ring, which also houses the amygdala and the hypothalamus. Now, pain is a perception by the brain of a stimulus. It's subjective perception. It is a sensory process perception that depends on how the brain receives and interprets nociceptive information, neuropathic information. And there are two basic processes in that sensation: the ascending pain impulse transmission and the descending modulatory or inhibitory tracts of that information. So pain is sensory information, as we've heard over the last day or so, from nociceptor and tactile receptors transduced into action potentials and then sent to and perceived by the brain. Now, transduction means that there's a process that goes on of converting sensory stimuli into action potentials. We are really a big electric system. That's basically what we're made of. And then perception is whereby the central nervous system and the brain processing of these impulses then interprets the pain event and calls for protective action. If the brain perceives sensory information to be threatening, whether it's a real threat or an imagined threat, there's what's called the activation of the fear response, the HPA axis, which is hypothalamus pituitary adrenal axis. And the thalamus and the limbic system sends an alarm to the autonomic nervous system and the pituitary gland, which triggers adrenal and allied glands to activate all kinds of chemicals that are referred to as catecholamines, such as adrenaline, noradrenaline, cortisol, for preparation of the body for the fight or flight survival response. The system now is in a fear mode. Pain is a noxious signal from nociceptor sensors to the brain, which the brain then translates the information as dangerous to the body, and it activates the HPA axis. Here's your HPA axis. You all for sure know that your adrenal glands are on top of your kidneys. And ACTH means adrenocorticotropin hormones, which go and finally and release through the blood system cortisol and all your other basically lethal chemicals. The HPA axis, by the way, was not intended to be constantly functioning, but functioning in a fear 911 flight response and then retrieve. But that does not always happen. So in the face of chronic activation, appropriate negative feedback within the axis can be disrupted to such an extent that these changes are considered to be maladaptive. From a clinical standpoint, these maladaptive changes in the HPA axis have been correlated with multiple subtypes of anxiety disorders, depressive illnesses, and chronic pain. And here are some of the references that I drew the information from. There was 2 years ago a major day-long seminar at the New York Academy of Sciences on the role of the HPA axis in obesity. So it's a very active system. And pain and negative emotion is, as we heard yesterday, very common in persons with MDD, which is major depressive disorders. And there have been a lot of researchers who have done research by various different formats and have concluded that at least 65% of patients with major depressive disorders comes comorbid with pain. And that's a repetition of what we heard yesterday. So what is current in music research? Not only music therapy research, but research in music that we can use as clinicians to translate into clinical work. So let me say a brief word, which will be a review of some of the pleasure centers that work in our systems. When the cortex receives and processes sensory information, indicating a reward, it sends a signal announcing this reward to the particular part of the midbrain, which is called the ventral tegmental area, VTA, keep that in mind because the research that I'm going to talk about coming up deals with research in these areas. The VTA then releases dopamine, which is the feel-good hormone, not only into the nucleus accumbens, but also into the septum, the amygdala, and the prefrontal cortex, which then tells you this feels good. The nucleus accumbens then activates the individual's motor function. You heard Dr. Tremo talk a lot about sensory motor stimulation, while the prefrontal cortex focuses his or her attention on, for example, the music. So this is the first research that I'm going to present to you. I didn't do the research. It was done up at McGill at the Brain Center by Robert Zatori, who is a music psychologist who does a lot of research on the brain, and his staff. And the question was, is there a systematic relationship between dynamic increases in pleasure states of listening to music and physiological indicators of emotional arousal, including changes in heart rate, respiration, areas that Dr. Tremo mentioned earlier can be tracked, plus brain function. And the design of the study was that they had a group of students that were asked to self-select music that gives them the chills. And there were across genres, which included the Impressionists and Beethoven and Barbara rock and whatever. Now, the translation, in my opinion, of the study into music-based treatment for pain perception is if the areas linked to anticipation connects with brain parts involved in making predictions and responding to the environment, while the area reacting to the peak moment itself is linked to the brain's limbic system, the emotional system, then the role of music listening can work to modulate fear, anxiety, which is what the system is in. So this is just one way, and it's dealing with the listening aspect of music. So music-based treatment then, in terms of listening to music, is more than just a pain distractor. It is proven to be pleasurable and emotionally arousing, proven to be. So pleasure can relieve the HPA axis. We need research in that area from its fear modality by modulating the excitatory catecholamines. So here's some further questions for forefront research. How long-lasting could this relief from fear to pleasure extend? When and what kind of music for emotional arousal could influence pain perception? How should treatment protocol be prescribed? And does making music have similar results in releasing dopamine? I have not been able to find what I felt to be adequate research in those areas. Now, here's a research that I discovered. This is very recent. Well, it's 1999. It was done in Germany on rhythm, relaxation, music therapy, and cancer pain. And the objective here was the registration of the influence of musical rhythm on synchronization and coordination of heart rate, what we heard yesterday called entrainment. So the design was a randomized pilot study of 28 patients with chronic cancer pain who were in a stable phase of the disease. And the intervention was 14 days daily training of a relaxation therapy designed for improving the falling asleep factor, which included a 30-minute lullaby-like, rhythmically dominated music with generally decreasing tempo. An interesting design. No training was given to the control group. So, and that's the reference for that. So the measurements procedures were very rigorous. They had continuous registration of heart rate and comparison with musical beat on the first day of the training and on the 15th day, the day after the training. And there was the analysis of the degree of synchronization, that is the coordination of the systolic beat and the musical central time point. And they used a 6/8 apparently music. The paper did not list what exactly was the music. The recording of the time of falling asleep and the registration of the patient's subjective evaluation, I guess the rating on a scale of 1 to 5, therapy, and the pain intensity using the verbal rating scales that are available for pain rating. And there was a documentation of the amount of use of analgesic over the 14 days. Here are the results. The relaxation therapy trained patients showed an increasing synchronization and coordination of heart rate and musical beat, which is entrainment, at a tempo between 48 and 42, which is quite slow and getting slower. They got a very stable 2 to 3 synchronization, which was probably for every 2 beats, 3 heartbeats. That would be the since the heart goes between 60 and 80 beats per minute. But they got the heart to synchronize. The trained patients who reported the best relaxing and analgesic effects showed the highest degree of synchronization. And relaxation therapy led to an improvement of falling asleep and to a decrease in consumption of analgesics. This is a proven documentation of the impact of this particular approach. So the researchers concluded that a lullaby-like music within a special range of tempi can induce a trainable, you can actually train the system to synchronize heart rate functionally associated with the formation and intensity of a relaxation reaction. Researchers noted at the end that further investigations showed promise, but they needed a substantial improvement in the measurement and documentation methods. So here's what I would consider it to be a translation of this research into integrative music-based treatment. Integrative music-based treatment included the mind-body stress reduction therapies, can reduce stress on an extended basis, influencing calmness, rest, and better pain coping. So we're talking now about uniting with mind-body persons. Possible pre- and post-operative stress reduction training provided jointly by music clinicians and mind-body therapists may achieve longer-lasting pain coping skills. So dose response, which is my pet peeve because we never seem to discuss how much of what kind for how often, dose response implied in this research could be replicated into, if we were going to take this kind of a project, 14 days of pre-op training, followed by 14 days continuation post-op, and then a continuation on an outpatient rehabilitation status. And the overall treatment could begin with the music listening segments, followed by a gradual introduction of participatory instrumental and vocal music making interventions. So I see a very wide opportunity now to develop the kind of treatment based on this type of research. And the last research that I'm going to present to you was just published in September of 2011, which is, these people did a very, very profound acoustic analysis and mood classification of pain-relieving music. So in previous researches, there was with a wide range of music genres and tempos and structures chosen by participants. It had been assumed that music structure did not play a significant role. Rather, the listening to preferred music rendered the music what they called functionally equivalent as regards its effect on pain perception. But the actual music components itself were never really investigated. So this study sought to challenge previous assumptions by performing more detailed and complex analysis of a selection of music chosen from 3 different pain studies. I'm not going to go into the intense an analytical process they went through because that would be the rest of the day. Whoops.
You got it.
So I keep leaning on the wire. So the timbre, everybody understands what timbre is, yes? And tonal aspects of the music correlate with pain tolerance and perceived pain intensity. Music analysis in this research showed significant correlation between timbral and tonal aspects of music and measurements of pain tolerance and perceived pain intensity. Mood classification here indicated that the majority of the patient-chosen music expressed contentment, which we already heard Bob Zattori tell us. Researchers found that in addition to the personal preference factor, the emotion expressed by and within the music itself, as defined by its acoustical content, is important to enhancing emotional engagement with music and therefore enhances the level of pain reduction and tolerance. So we're talking about the music itself having within it the emotional content that then draws the emotional engagement from the patient. So the researchers concluded the results suggest that music content and structure may also play a role in the many choices made by participants and therefore the efficacy of music listening for pain relief. Now, I'm sure that music playing for patients and with patients would clearly have a similar indication. Music chosen by participants predominantly expresses contentment, is generally brighter than other music, and more major in key tonalities, harmony. Acoustical features are key to determining the emotion expressed by the music, and the timbral and tonal features are shown to be significantly correlated with measurements of pain tolerance and perceived pain intensity. It is suggested that the acoustical content and emotion expressed by a piece of music contribute toward the participant's emotional engagement with music and enhances distraction from pain. So here, music-based treatment clearly indicated, and that the patient-selected music for listening brings about a sense of safety, calming the HPA axis. That patient-selected music emits a flow of dopamine, which brings about happier, calmer HPA demeanor, and that timbre, which is the type of the instrument, and tonalities, simple melodic contours with close range intervals and simplified chord progressions, impact also on pain perception. So here's some frontier thinking about research that we need to do in music medicine. Dr. Ari Goldberger, who I'm sure Dr. Trano knows, from Boston, has a program called Heart Songs, and he investigated, he claims the biological structures operate in complex fractal patterns. I'm not defining fractal. Google it and you'll understand. Replicated, I don't have all day to talk to you, but you can do that. Fractals is, a snowflake is a fractal. Okay, self-replicating, anyway, replicated in architecture and music. Music has fractal components. There is an article in the journal that I am editor of, Journal of Biomusical Engineering, by a Dr. Dan Schneck, who talks about fractals and music. Melodies derived from, this is Dr. Goldberger, they present melodies derived from ECG, electrocardiogram, electric frequencies, which are translated into pitches and digitally recorded. Heart songs contain the musical notes that were mapped from heartbeat data, the melodic contours digitally recorded, and then harmony added to it. And he claims that heart anomalies can be detected and perhaps forestalled by such recordings through this clinical analytical procedure that translates heart rhythm into melodic contours. Now, this may be really way out forefront, or it may really have some meaning because we are, after all, electric frequencies. So this is in one of my books that's out there. David Teller.
It's a circus trick.
It's what?
It's just a circus trick.
It may be a circus trick, but any trick that reduces pain works. So maybe we should take people to the circus. The point is, that would be a great release of tension. The point is not whether it's a circus trick. The point is, how far can we go when we talk about music? And he's always arguing with me anyway. When we talk about music, in researching exactly what this whole phenomenon called music is. So David Teller had a poster at the New York Academy of Science conference last March, and he explores listening to music while using something called a heart tuner to record his external electromagnetic field. And he says, note the fourth peak from the left. This seems to be the harmonic connection. This is him. I don't know that this is necessarily fact, but an interesting idea. between the thinking mind and the feeling heart that hovers between 7.5 and 9 cycles per second. Look how far off the chart it goes. I do this consciously. Maybe David is at the circus, but still giving us interesting information. He says, concentrating on music and watching my EM field dance is both an enlightening and empowering experience. It also feels great, and it's loads of fun. So, and the music he's listening to is Saturday Night Fever. That's what's going on here. So if we all have a kind of electromagnetic field, is an electromagnetic field different when the body is in pain? Could changes in the electric field through music interventions therefore reflect possible reduction of pain, especially if mind-heart reaches peak experience that Satori talked about with music? Perhaps seeing which spectral peak is activated during a pain event would be useful in finding harmonics to lessen pain. Binaural and microtone stimulation might be useful in this regard. Here we call for research. Could signals from nociceptive sensors be digitally recorded into melodic contours that could be composed and played to resonate with and alter the pain? This may be far out thinking, but with all the technology that we have, I still feel that we need to go further into the science about music. Could the HPA axis thus be quieted if music could then change nociceptive action potential signals that are going to the brain? Could music already be doing this? I don't know. I have not seen the research. If you have, send me an email. I'll be very happy to read the papers. So here are some recommendations. To the music-based clinicians that are attending, let's know, understand, and learn more scientific and medical terminologies and research terminologies. My cousin, who is here, she's a psychologist whose son is a neurologist, a big neurologist in Boston, informs me that medical people have their language and they don't want to hear ours, at least predominantly. I'm done. Let's go beyond the fact that music simply does something. Let's now explore how and what of the music does it, and could it do more? Let's innovate empirical clinical research to indicate what differentiates music-based treatment from other distracting interventions, playing chess or going to the circus. What precisely is unique about the elements of music and how these interact with physiologic function for a system in pain or HPA-driven? And to the medical professions, music is a serious resource in medical treatments. We have to appreciate that music contains powerful elements that the human body understands, because the human body put music out there. And these are what it understands: periodicity, complex frequencies, energy, and structure. Music therapy is a treatment, not just a pleasant entertainment. Learn about music and how far music-based treatment can reach. Open your minds and think beyond. Assist in developing empirical research on music's impact and what, how, and how much about music elements that can change pain perception. But let us also accept that sometimes even music cannot substitute for tears. Thank you.